Hi everyone, I'm Anchi Jiao. Today I want to talk about the treatment of darolutamide for non-metastatic castration-resistant prostate cancer. Prostate cancer, or PC for short, is a high incidence of tumor in men. According to the World Health Organization, PC is the second common male cancer, and the fifth cause of cancer-related death. Androgen deprivation therapy, or ADT for short, can effectively reduce the rate of testicular testosterone synthesis and androgen levels in the blood, cause prostate gland regression, is the main treatment of local or advanced PC, but about 1/3 of the patients after a period of ADT will eventually build up resistance to the treatments and develop a more aggressive form of the disease called castration-resistant prostate cancer, or short for CRPC, that is associated with tumor progression and poor prognosis. Such patients usually have increases in prostate-specific antigen. Some patients with CRPC have no evidence of imaging metastasis, which are non-metastatic CRPC, or short for NMCRPC, and delaying tumor metastasis is the most critical treatment target. NMCRPC is usually caused by abnormalities in the androgen receptor, or short for AR, or AR signaling pathway, as shown by studies demonstrating the role of autocrine synthesis of androgens and AR protein overexpression in NMCRPC. AR aberrations commonly associated with NMCRPC include AR amplifications, mutations, and constitutively active AR splice variants. Amplification of the AR gene leading to AR protein overexpression and mutations in the ligand-binding domain of AR can make the receptor more sensitive to growth-stimulating effects of low androgen concentrations, and turn antagonist responses to agonistic. Certain AR mutations have been linked to the development of resistance to specific anti-androgens. Therefore, AR signaling blockers became the focus of the development of therapeutic agents for NMCRPC. Previous use in NMCRPC, first-generation AR inhibitors, such as bicalutamide or flutamide, as well as the androgen biosynthesis inhibitor ketoconazole, have been shown not to bring survival benefit. Second-generation AR inhibitors have AR selectivity and affinity, significantly prolong metastasis-free survival, and reduce androgen and serum PSA in blood circulation and tumor tissues. Darolutamide is a novel oral AR antagonist, which has recently completed a pivotal phase 3 clinical study to determine its efficacy in non-metastatic castration-resistant prostate cancer. It has a unique chemical structure, exists as two pharmacologically active diastereomers, S, R, and S, S, darolutamide, and forms darolutamide as main metabolite in patients, which are all pharmacologically active. Darolutamide competitively inhibits androgen binding, AR nuclear transport, and AR-mediated transcription, with a stronger affinity for AR than the first two second-generation AR inhibitors, enzalutamide and alprotamide, and with an inhibitory activity against multiple AR mutations that cause resistance to other AR inhibitors. Moreover, Phase 2 and 3 data demonstrate high antitumor activity and a very safe toxicity profile, similar to placebo in the ARMIS study. Ongoing studies are underway with the goal of expanding the potential use of darolutamide for advanced prostate cancer, including the ARISONS trial in MCSPC, the results of which are eagerly awaited. One potential advantage of darolutamide is the lower risk of cytochrome P450 drug-drug interactions, since several patients with advanced prostate cancer have significant comorbidities and are usually receiving multiple concurrent medications. Differently from enzalutamide and apalutamide, which are strong CYP3A4 inducers, a recent study with darolutamide has shown no clinically relevant inhibition of CYP1A2, 2A6, 2B6, 2C8, 2C9, 2C19, 2D6, 2 times 10 to the power of 1, or 3A4. It is possible that this difference regarding drug-drug interactions may be the reason why there were no significant differences in terms of toxicity between darolutamide and placebo in the ARAMIS trial, considering that 98% of the patients on the trial were receiving at least one concurrent medication. For this reason, darolutamide might be the most attractive partner for combination with other AR-directed and non-AR agents in future clinical trials. Furthermore, due to less CNS penetration and central adverse events, darolutamide may theoretically cause less additive side effects when combined with other agents that may cross the blood-brain barrier. In addition, this agent could potentially be tested in patients with CNS disorders such as cognitive impairment, dementia, ataxia, apraxia without worsening such conditions, while enzalutamide and apalutamide would generally be discouraged in these settings. However, darolutamide also faces certain challenges moving forward. First, it is the third drug to market for the NMCRPC indication, and it may have trouble capturing a market share due to the existing familiarity of the other two AR-directed agents. Second, there is a concern that the ARASENS trial might be a negative study. To this end, in the ENZAMIT trial, the added value of enzalutamide in men who also received upfront docetaxel chemotherapy was more questionable in terms of overall survival gains. So it is possible that the use of darolutamide in a population of patients, all of whom are already getting chemohormonal therapy, may not translate into a survival benefit. Finally, it is unlikely that darolutamide will obtain an indication for use in the MCRPC space anytime soon, as there are currently no ongoing pivotal trials testing this agent in the MCRPC population. Indeed, such trials would be difficult to conduct, and would probably require some type of head-to-head comparison against apalutamide or enzalutamide. Nevertheless, the availability of one more AR-targeting agent in our therapeutic armamentarium is a welcome addition, and may lead to cost reductions in a competitive marketplace. The ongoing trials with darolutamide and the future combination strategies are likely to shed additional light on other uses for this drug, as well as the optimal combinations for synergy. These and other studies will keep the field busy for many years to come. That's all the content of this video. Thank you for watching it, and I look forward to the criticism and correction.